I'd like to thank everybody for tuning in today to the visual field testing lecture that we're going to give. We have 3 speakers today. It'll be Jeff Suhu, who's Assistant Professor of Ophthalmology at the University of Colorado, Leo Seibold, who's also Assistant Professor of Ophthalmology at the university, and I'm Malik Kahuk, Professor of Ophthalmology and Chief of the Glaucoma Service at the University of Colorado School of Medicine. We're going to get started first of all with Dr. Suhu going over the basics of the Humphrey visual field, followed by Dr. Seibold going over some alternative testing in the arena visual field, and then I'll finish things off with some pearls for reading the visual field, as well as some of the pitfalls that might occur when interpreting the visual field. So I'm going to hand it over to Dr. Suhu, and we'll get started.
We'll get started with a couple basics. As you should know, glaucoma is a characteristic optic neuropathy with multiple risk factors. There's progressive injury to retinal ganglion cells and axons, which leads to a specific pattern of optic atrophy, as well as associated visual function deficits. The assessment and documentation of the nerve and the visual field are essential to both the diagnosis as well as the follow-up and treatment of glaucoma. The impact of glaucomatous visual field loss is such that glaucoma patients can be at increased risk of car accidents, increased risk of falls, or trouble with other activities of daily living. The field of vision is defined as the area that is perceived simultaneously by a fixating eye. In the light-adapted state, the island of vision has a steep central peak that corresponds to the fovea, the area of greatest retinal sensitivity. This is a schematic of what we mean by the hill of vision, and you'll see that the point of fixation is the highest point of retinal sensitivity. The limits of the normal visual field are 60 degrees superiorly, about 70 to 75 degrees inferiorly, greatest temporally at over 100 degrees, and nasally about 60 degrees. There are different types of perimetry available. Kinetic perimetry, as the name implies, involves a moving stimulus, where a stimulus is moved from a non-seen area of the visual field into a seen area. The procedure is repeated with use of stimuli along other meridians, often spaced about every 15 degrees. One attempts to find locations in the visual field of equal retinal sensitivity to define the visual field. Goldmann perimetry is the classic kinetic perimetry, and the Goldmann allows for different sizes of the test stimulus as well as different illuminations. This is a sample of a kinetic perimetry plot, and you can see the different Roman numerals, numbers, and letters that indicate the isopters, the different size targets that are seen in each defined area. Static perimetry is more commonly used, and in this type of perimetry, the size and location of the test target remain constant. The retinal sensitivity at a specific location is then determined by varying the brightness of the test target. Here we see another schematic of the hill of vision, but once again, the peak is greatest centrally at the point of fixation and decreases out toward the periphery. The Humphrey visual field, most commonly used in testing for glaucoma, a common test pattern is the 24-2 test protocol. The first number refers to the number of degrees of the field tested from the point of fixation. So for instance, a 10-2 means that the machine test points 10 degrees from the center of vision, and a 24-2 test points 24 degrees around the fovea. The second number refers to the testing protocol. The Humphrey visual field historically has 2 testing protocols, Protocol 1 and 2. Protocol 1 test points directly on the horizontal and vertical axes. Protocol 2 eliminates these points since they can be difficult to interpret, and Protocol 2 is more commonly used. The 24-2 eliminates the most peripheral ring of test locations compared to Program 30-2, except in the nasal step region. This is useful because the peripheral ring provides less reliable data, and it allows for the testing time to be shortened. The nasal step 30 degrees is preserved in the 24-2 to enhance in the diagnosis of glaucoma since defects often originate in the nasal visual field. The automated perimeter measures the ability of the eye to detect a difference in contrast between a test target and the background luminance. The differential light threshold, or the threshold target, is designated as the dimmest target that is seen 50% of the time. Stimuli that are suprathreshold are brighter than threshold stimuli and are seen more than 50% of the time, versus infrathreshold stimuli, which are seen less than 50% of the time. The frequency of seeing curve is generated by testing one retinal location multiple times with different stimulus intensities. The frequency of seeing curve is the graph of the percentage of stimuli seen at each intensity level. The threshold is then read off the graph at the 50th percentile. This is a schematic of a frequency of seeing curve, noting that dimmer lights that are infrathreshold and suprathreshold lights are brighter. The decibel value of the 50th percentile of stimuli seen is then designated as the threshold value. It's difficult, however, to perform these types of curves at a large number of locations, so a staircase or bracketing strategy is used to estimate the threshold. Most commonly, an algorithm moving in brackets of 4 and 2 decibels is employed. Testing starts with either a suprathreshold or an infrathreshold stimulus, and the intensity of the stimulus is changed in 4 decibel steps until the stimulus is no longer seen, which means that the threshold has been crossed. The stimulus then reverses, becoming brighter in 2 decibel steps until the stimulus is seen again. This is a schematic of that bracketing method showing the attempt by the perimeter to define the threshold value by going up and down in the stimulus intensity. The Humphrey perimeter uses the intensity of the last seen stimulus as the threshold value. The octopus perimeter estimates threshold as the average of the last seen and unseen stimulus intensities. A full thresholding program defines the threshold at every single point in the testing field. This is the most accurate way of evaluating and following glaucomatous visual field defects. However, it is the most time-consuming method. There are a number of reliability indices present during the testing period. During the test, a stimulus of maximum luminance is periodically presented in the patient's blind spot, where they should not be seen. If a patient responds to the stimulus, it is counted as a fixation loss. There are also false positive cues, in which a sound cue is given before each stimulus. Periodically, the sound cue is given without a test stimulus, and a false positive result is noted if the patient responds to the sound cue alone in the absence of a light stimulus. A false negative response is recorded if a patient does not respond to a stimulus at a location that has previously had a measurable threshold earlier in the test. A high number of false negatives can indicate the patient is not paying attention, and it can make the visual field unreliable. At the bottom of the printout is the gaze tracker strip, which shows how often and how far away from fixation a patient looks away during the test. Small downward deviations in the gaze tracker indicate that the gaze tracking system was unable to detect the patient's gaze, and large downward deviations are from patient blinking. As mentioned before, the stimulus size varies. The Roman numeral represents the size of the object, and classically from Goldmann size 0, 1/16 of a millimeter squared, to Goldmann size 5, 64 millimeters squared. Each size increment equals a 2-fold increase in diameter, and therefore a 4-fold increase in area of the stimulus. The Goldmann perimeter and the Humphrey perimeter are a calibrated bowl with a background intensity of 31.5 apostobes, which is marginally photopic. This is to allow for stimulation of both rods and cones. A commonly used algorithm in place of full threshold strategy is the Swedish interactive threshold algorithm. This is designed to decrease the amount of test time by incorporating the patient's responses during the test in real time. Threshold values are constantly calculated throughout the test at similar points. If the results vary too much, points can be tested again. Therefore, these faster protocols are generally preferred to full threshold testing in order to avoid patient fatigue. Uncorrected refractive error causes defocusing of the test target and can make retinal sensitivity appear worse than it really is. A proper near-ad refraction, determined by the patient's age, must be used. The lens also must be positioned properly in front of the patient to prevent artifactual defects caused by the rim of the lens. The age of the patient is essential, as the patient's responses are compared to age-matched normals during testing analysis. Numeric data can be helpful as it gives the total patient responses in decibels. We will also look at pattern and mean deviation, which are evaluations of the patient's responses compared to age-matched controls. The total deviation is a comparison of the patient's responses with that of known normal patients of their age, and a representation of this relationship is shown both in numbers and the probability plots. Pattern deviation removes generalized depressions, helping to isolate patterns such as glaucoma. The mean deviation is the average of all the numbers in the total deviation plot, and it indicates the overall deviation of the visual field from normal. Numbers that are positive indicate an elevated field, or a field that is seeing more than would be expected for an age-matched control. Negative numbers indicate a depressed field that is seeing less than an age-matched control. The difference in the mean sensitivity between a patient's two eyes is usually less than 1 decibel. Inter-eye differences greater than these values are suspicious if they are explained by non-glaucomatous factors, if they are not explained by non-glaucomatous factors, such as cataract or miosis. The pattern standard deviation is a measurement of the degree to which the shape of the patient's measured field departs from the normal age-corrected reference field. A low pattern deviation indicates a smooth hill of vision, and a high pattern standard deviation indicates an irregular hill. Pattern standard deviation can help to characterize localized changes in the visual field. We'd like to present 5 rules for interpretation of visual fields. We're calling the 5 R's. Was the right test performed? Is the test reliable? The probability plots need to be reviewed. Does the pattern of loss correspond to the retinal nerve fiber layer? And you need to reaffirm the diagnosis of glaucoma or something else that could cause a visual field defect. Rule number 1, make sure the correct test was used. Is this the right strategy? Generally, we use CETA standard. Is this the right test stimulus size? Size 3 is standard. Size 5 is used for advanced glaucoma and decreased visual acuity. Was the right field size chosen? As we mentioned before, a central 24-2 test is commonly used. A 10-2 test can be used with visual field loss within the central 10 degrees of fixation. It should be noted that the test points are closer together with a 10-2 test, being spaced only 2 degrees apart, compared to 6 degrees in a 24-2 or a 30-2 test protocol. Was the right age and date of birth entered? This is important because the normative database is based on age. Is the refractive error correct? And is the pupil size correct? Small pupil sizes can limit the visual field and lead to falsely depressed visual fields. Rule number 2, check the reliability of the field. What is the fixation loss rate? What is the false positive and false negative rate? Lower rates are better and indicate a more reliable field. A high false negative rate may reflect both fatigue or advanced visual field loss. Anything over 25% should be interpreted with caution. Fixation losses increase if the patient does not maintain good fixation, or if the blind spot was incorrectly mapped at the beginning of the test. A high rate of fixation loss can make a test unreliable or difficult to interpret. Here we see a classic cloverleaf pattern with a high false negative rate, showing significant depressions in all four quadrants. This is often a sign that a patient has fatigued and is testing poorly or lost concentration. The probability plots in the bottom of the printout then need to be reviewed. The more negative the mean deviation is, the worse that the field is. A p-value is given to show the probability that this particular mean deviation would occur in a normal population. As mentioned before, the pattern standard deviation is a measure of focal visual field loss. A higher pattern standard deviation suggests more localized field damage. In advanced glaucoma, when the entire visual field is more affected, the pattern standard deviation can actually decrease because the damage has become less focal. The two probability plots at the bottom, the left is the total deviation and the right is the pattern deviation. The total deviation shows deviations at each test point from age-matched controls. The pattern deviation removes any generalized depression from the field, such as might be seen with cataract, to highlight patterns of visual field loss that are more focal. The grayscale in the upper right is useful for patient education, but should not otherwise be used to interpret the visual field. The grayscale and probability plots don't always agree. Here, we see a relatively deep inferior arcuate scotoma, which doesn't show up as a significant defect on the grayscale plot. The total deviation and pattern deviation are the most useful aspects of automated perimetry due to the comparison to a normative age-matched database. It's important to examine depressed points, to pay attention to contiguous depressed points, the location, and the severity. As you see in the bottom legend, the different boxes vary in terms of the degree to which that test point differs from the age-matched control. The darker boxes indicate worse depression, such as would be seen in less than 0.5% of a normal population. Here we see the other indices that are shown in the printout, the glaucoma hemifield test, which we'll talk about in a moment, the mean deviation, and the pattern standard deviation as expressed in decibels. The glaucoma hemifield test compares similar areas in the superior and inferior visual fields. Upper and lower fields differ in less than 1% of normal controls. So when they differ significantly, the glaucoma hemifield test will be outside normal limits, suggesting that glaucoma is more likely. When evaluating for glaucoma, you want to see if the visual field defects correspond to the retinal nerve fiber layer. The pattern deviation should be consistent with glaucomatous damage of nerve fiber layer bundles. Paracentral defects can be very small and difficult to see on a 24-2. Given that the test points with a 10-2 are closer together, they may be easier to see on a 10-2 central visual field. As mentioned before, anything that causes generalized field loss can obscure more localized defects. A cataract, for instance, would make the total deviation look overall depressed. You see the pattern deviation corrects for this generalized field loss and highlights the focal nature of the superior arcuate defect in this patient. Nasal loss is more common in glaucoma. This is why the 24-2 visual field preserves 30 degrees of the nasal visual field for testing. Since the nasal visual field loss here in the superior quadrant compared to the inferior quadrant differs significantly, the glaucoma hemifield test flags this as being outside normal limits. Arcuate loss is another common pattern of nerve fiber layer loss seen in glaucoma. Hemifield loss is common in advanced glaucoma, although can also be seen in other pathologic conditions, such as retinal vein occlusion or ischemic optic neuropathy. This makes it important to reaffirm the diagnosis when interpreting a visual field. You need to assess the retina and the optic nerve to make sure that they are consistent with the visual field. A visual field that indicates advanced visual field loss without concurrent cupping seen in the optic nerve may suggest a different etiology for the visual field loss. It's important to confirm an abnormal field even in experienced test takers. In the ocular hypertension treatment study, over 85% of abnormal fields reverted to normal on subsequent testing. Once you've defined the patient's field loss and correlated it with their optic nerve, you want to figure out where they are on the continuum of glaucoma and correlate loss of structure and functional loss. This can guide your treatment of patients with glaucoma. We'll now move to Dr. Seibold, who'll be talking about other aspects of selective functional testing.
Okay, so we'll move on to selective functional testing here. So the ultimate goal of selective testing is earlier detection. The big problem with standard perimetry is that up to 40% of the retinal ganglion cells can be lost before we see any functional defects. So this leaves a big window for improvement in earlier detection of disease. Selective functional testing targets individual components of the anterior visual pathway. The goal here is to isolate the response characteristics of different types of ganglion cells to develop a more sensitive test. If we can detect disease earlier, we can start treatment earlier and hopefully improve long-term outcomes. So there's over 26 different types of retinal ganglion cells in the human retina. The primary ones we're concerned with are grouped into one of three different visual pathways. The ganglion cells in the magnocellular pathway have a fairly large dendritic field. It processes information with a very low spatial resolution, and it doesn't give you much fine detail, but what it does process is information concerning motion. These are phasic firing cells, so they fire in response to object motion, but carry no information regarding color. The parvocellular system, which is around 90% of the retinal ganglion cells, is concentrated in the central retina and has a fairly small dendritic field. They convey very high resolution information regarding the details of an object, but they're fairly motion insensitive. They also process components of the red-green color vision. In the coniocellular pathway, bistratified ganglion cells project the lateral geniculate body and also are very motion insensitive, but like the magnocellular system, they're fairly large in their dendritic field, so they don't convey a lot of fine detail, and they're responsible for carrying blue and yellow color vision. Blue light activates these ganglion cells, while white light inactivates the system. Input from red and green cones also turn off the system. So with conventional perimetry, we're using a broadband white stimulus that's illuminated across the retina. And this is not selected to any particular ganglion cell type. They can all be activated by this stimulus. Furthermore, you have three different retinal ganglion cell types scattered across the retina in sort of a mosaic pattern with overlapping dendritic fields. So you can selectively lose an entire group of ganglion cells in one particular region of the retina but because of these overlapping dendritic fields, there's a high probability that it's going to be missed on standard perimetry. So this loss can then continue on until we've wiped out a fairly large portion of the retinal ganglion cells in a certain region. So as a result, we have this redundancy and a relatively low sensitivity for detecting disease in standard perimetry. With selective testing, we're providing you a way to look at individual ganglion cell pathways and increase our sensitivity for detecting earlier disease. So the first selective vision pathway that we'll talk about is that coniocellular pathway, and this is what's tested with SWAP testing, or short wavelength automated perimetry. And it emphasizes the characteristics of those bistratified retinal ganglion cells. It does this by projecting a blue stimulus on a yellow background. By bleaching the retina with this bright yellow light, the red and green cones are fatigued, allowing for that selective activation of the blue cones using a size 5 blue stimulus. Since you're only looking at one of the three vision pathways now, the redundancy of the system is eliminated, so far fewer cells can be lost before a defect is detected, at least compared to standard perimetry. So SWAP testing has been shown in 2 independent longitudinal studies to detect glaucomatous defects by as much as 5 years earlier than what's found on standard automated perimetry. They were predictive of both the onset and location of future standard automated perimetry defects. These scotomas also correlated fairly well with the optic disc changes that we see in glaucoma. SWAP testing can be frequently abnormal, though, in glaucoma suspects and in up to a third of ocular hypertensives. But the defects in SWAP testing tend to be larger than those on standard perimetry in patients who have confirmed defects on that standard perimetry. So in the bottom, you can see how these 2 tests compare in a patient with early left-sided hemispheric plaques and MS. As you can see in the standard automated perimetry, the testing looks fairly normal, but there's an obvious homonymous defect showing up in SWAP testing. So this is just a comparison of some of the parameters from standard automated perimetry and SWAP testing. As you can see with standard perimetry, a white stimulus is projected against a white background. With SWAP testing, you're using a blue stimulus against a yellow background. You're also using a larger size 5 stimulus as standard with SWAP due to the relative insensitivity of the pathway and also the decreased brightness compared to standard testing. And then as you see, the duration times of the stimulus are similar. So there's a few limitations of SWAP testing. The main problem with the initial version of SWAP testing was that it's a fairly difficult and prolonged test, taking almost 10 to 15 minutes per eye to complete. As you know, with the difficulty most patients have with visual field testing, they're not going to tolerate a test that long. And also the short and long-term variability also appear to be greater with SWAP testing compared to standard automated perimetry. But now using the CETA algorithm, you can drastically reduce testing time to about 3.5 minutes per eye. This not only compresses the testing time, but it also tightens up your confidence intervals and decreases that threshold variability that was a problem to begin with. And finally, SWAP testing is vulnerable to media opacities, especially those aging effects of the crystalline lens we see in cataract formation. That lens over time becomes more of a blue filter that can result in decreased or that could result in depression of sensitivity and might contribute to a higher threshold variability as well. So the second type of selective visual testing that we'll talk about is the frequency doubling technology. Selective functional testing with FDT, or frequency doubling, exploits this frequency doubling illusion that was initially described in the 1960s by Kelly. In this illusion, you're seeing a grating of black and white bars that's counterphase flickered at a very high frequency. So to a retinal ganglion cell, these flickering bars look like an object that's actually moving across the retinal surface. And the illusion is the perception here that you actually have twice as many bars as there actually is in the stimulus. So the FDT testing emphasizes those magnocellular responses. The magnocellular pathway is the one that was very sensitive to motion. So by using this moving achromatic stimulus, we're selecting out a very small portion of the M cells in that magnocellular pathway. These only account for about 3 to 5% of all retinal ganglion cells. So we're selecting it out a very small, specific group of ganglion cells in order to reduce that redundancy of the system again. And by doing that, we can hopefully improve our detection of that early disease. So how well does FDT work in detecting early glaucoma? Well, when comparing established visual field defects, they tend to correlate fairly well with standard automated perimetry, having a very high sensitivity and specificity for detecting defects that are already there on standard perimetry. It's similar to SWAP, though. In very early glaucoma or suspects or ocular hypertensives, it can often predict defects that show up later in automated perimetry by as much as 3 to 5 years. So when using it as a screening device, the criteria, though, for an abnormal test are somewhat vague, though. Perhaps the best criteria was set forth by Quigley, where he found that the presence of 2 or more abnormal locations, regardless of the severity, was indicative of likely disease. This resulted in a sensitivity of 91% and a specificity of 94%. However, a much larger population-based screening of 5,000 eyes found a much more modest sensitivity of 55%, but still a very high specificity. So one of the problems with the original version of FDT that you see on the top here was that the spot sizes were rather large, covering a 10 by 10 degree square. So this gave you a fairly limited resolution across the entire visual field, with only about 17 to 19 spots being tested. This limited the machine's ability to detect very small or focal defects and also detect small changes over time. Now with the latest version, called FDT Matrix, which you see in the lower portion there, uses a much smaller target size of 5 by 5 degrees square, which is similar, gives you a printout similar to a standard 24-2 visual field. And it appears the sensitivity is similar to that, again, of standard perimetry in detecting moderate to advanced disease, while giving you improved sensitivity for detecting that early disease that we want to catch. So the data validating its use, though, are still limited thus far for this version of the technology. So the advantages of FDT are that it's relatively low cost, it's compact, in most cases it's portable as well. So for super threshold testing, you can do a test in less than a minute. These features make it a good screening modality with the ability to test multiple patients in a relatively short period. And the results are fairly unaffected by at least moderate refractive errors up to 7 diopters. The disadvantages of FDT are that with the newer FDT Matrix, which, as we talked about, increases resolution and sensitivity, you're also increasing your testing time. So you don't get those quick 1-minute tests with that higher resolution testing. Cataracts can also impair the sensitivity, although this is less of a factor compared to how it is with SWAP testing. And while it's good for detecting early disease, it still may not perform very well as far as monitoring progression over time compared to standard perimetry. So here's just a comparison of all the functional testing available in the same patient. This is a patient with early glaucoma who underwent standard perimetry, a SWAP, FDT, and then also the newer FDT Matrix, as you can see in the bottom. So on the top, you see with standard perimetry, there's a very faint, almost undetectable supranasal defect starting there that could easily be overlooked. But with SWAP testing, you see that supranasal step, which is much more obvious. Then below that, on the FDT, original FDT, you see 3 abnormal targets in the same area. And finally, the FDT Matrix, you can see that defect also with a little bit greater resolution and a little more obvious than the other testing as well. So comparison studies have shown that each of these tests can identify glaucoma a little bit better in different patients. And by combining one of the tests, or by combining more than one test in someone who's very suspicious for glaucoma, you then further increase your sensitivity to detect disease. And so finally, here's just an overview of sort of the advantages and disadvantages and perhaps the best use for each of these modalities. When comparing standard automated perimetry, you have to remember this is still the gold standard in glaucoma, and it's the endpoint required by the FDA for any long-term treatments. It's the most heavily studied. We have the best data on this as well, but it's not sensitive enough to detect those early glaucomatous changes that we want to. So its best use is to follow patients with established disease, getting a baseline field and following up for progression over time. With SWAP and FDT, they tend to come into play here when we're dealing with those patients who have pre-parametric or pre-standard perimetry disease to detect it at a much earlier stage. Swab testing can be performed as fast as standard automated perimetry and may be more sensitive in earlier disease. It's limited by its high variability and the effect of cataracts over time on the test results. So it's maybe best suited for patients who you're worried about early disease in younger patients before the onset of cataracts. For FDT, you're getting a very fast, portable, and less variable screening test for early glaucomatous damage, but it's limited by its poor ability to detect progression over time. But used appropriately, all three of these tests provide complementary information at various stages of the disease and provide their own unique information for the treating.
So we've heard a lot about basic Humphrey Visual Field, the standard automated perimetry that's performed, as well as some of the more novel testing like SWAP and FDT. What we'd like to do at this point is bring everything together with a few pearls for practice. If you're coming back to this course, you can fast forward to this last part and get a quick overview of some pearls for practice, and hopefully you can see that it's a tie-in to the previous two talks. From a printout interpretation, some of the major points are listed here. It's very important to confirm patient's name, ID number, and date of examination. When we're teaching our residents and fellows, this is really what we start out with. You need to make sure that the testing you're looking over is for the appropriate patient. You should identify which testing algorithm is being used, 24-2, 30-2, and make sure that it's consistent with the previous testing so that we're comparing apples to apples. Confirm that the appropriately sized target was used. So if you're using a size 3 target in one test, make sure that follow-up tests that are being compared are the same size target. And confirm that the testing strategy that was used is also similar, or the same, I should say, to the previously used testing strategies. Humphrey Visual Field targets come in various sizes, as you heard from Dr. Suhu. It can range from a Roman numeral 1 through 5, which correlates with a size of 0.25 to 64 millimeters squared. A size 3 stimulus is what's typically used for patients who have vision better than 2200. And you can also use a size 5 in patients who might have worse vision or who have a central visual field island that you're evaluating, so that you can get better information that can be compared across different visits. The testing strategy, CETA Fast versus CETA Standard, was designed to replace the full threshold testing. Most glaucoma specialists and most ophthalmologists who are following glaucoma patients routinely go with CETA Standard. It's expedited without eliminating any significant data, and that's what we're looking for, as much data as possible, but still making it patient-friendly so that the information is useful. CETA Fast is used in special situations of inattentiveness or in patients who have physical limitations where they can't sit through a very long test. Pupil size is also very important. I think this is something that's often overlooked on the printouts. When you're looking at the printout information like ID, patient name, and age, make sure you also glance over at pupil size. If it's less than 2 millimeters or over 6 millimeters, it may influence the test, and this is due to artifacts and light diffraction or induced aberrations from the pupil size. The appropriate refraction should be listed. Age-adjusted charts are available to the technician to correct the target distance requirement, which is 30 centimeters in the Humphrey Visual Field. The machine will also calculate the appropriate lens add needed if the patient's age and distance correction are recorded into the machine. Any astigmatism more than 1.25 diopter should also be corrected and addressed prior to initiation of the test. The date and time is noted, as well as the patient's age, like I mentioned earlier. Testing points for the Humphrey Visual Field are compared with age-matched control, so it's really important to make sure that we have the appropriate age taken into consideration before interpreting the field. Fixation losses, as well as false positives and negatives, should typically be less than 20 to 30% for the test to be considered clinically valuable and reliable. And testing time, typically under 5 minutes in experienced test takers, is also something that is given on the left-hand side of the printout and should be taken into account. We heard this before earlier in the talk from Dr. Suhu about the decibels and what's important. Points here that I have listed under the first bullet is really important as far as a pearl that you can take home. A value of 40 decibels or higher on this graph indicates that the patient may be trigger happy, and a typical normal decibel reading is around 30. The grayscale representation for the numeric decibel graph illustrates values closer to the 0 decibel with black and those closer to 50 decibels with white. The grayscale is of little value, I think, when interpreting and comparing across different visual fields, but is used for patient education. It's something that patients can visualize and really understand when you're showing them the grayscale versus showing them the specific numbers or the mean deviation and pattern deviation. The mean deviation is a representation of the depressed vision for each point when compared with the age-matched controls. It does not account for global depression from other sources such as cataracts or vitreous hemorrhage. And that's where pattern deviation comes in. It represents focal depressed areas in the points tested when accounting for overall depression as estimated by the mean deviation plot. This information allows the physician to analyze the data obtained while accounting for any depression of the hill of vision that might be caused by cataracts, vitreous hemorrhages, or other media opacities. The glaucoma hemifield test compares points in the upper field to corresponding points in the lower field and then interprets the results as either outside normal limits, borderline, or within normal limits. Pattern standard deviation, or PSD, provides information about localized loss. A high PSD indicates a non-uniform sensitivity loss. As glaucoma advances, the PSD may appear to improve due to global depression, and this is something that should be taken into account. Mean deviation is the average difference from normal expected values in the patient's particular age group. Typically, an MD or mean deviation of -2 or less could indicate glaucoma. Some of the pearls and pitfalls that I think are important: size target should typically be around 3 unless the patient has very bad vision, as I mentioned. Trigger-happy patients, you can see the technician should inform the patient that it is normal to have periods of no stimulus, as Dr. Suhu mentioned, and to wait patiently through them. High decibels over 40 on a decibel numeric graph typically indicates a patient who is trigger-happy. Pupil size needs to be consistent between the tests. If a patient is on pilocarpine, that's something that needs to be taken into account, and if the pupil is dilated, that can also make comparison between different visual fields less useful. Cataracts may be a source of depression of the mean deviation. After cataract surgery, you might notice some changes that should be taken into account when comparing to tests prior to cataract surgery. Patient age should be noted with each test, and again, we're repeating this over and over again because I think it's really important to note that there's a significant change in the probability plot as the patient crosses into a new decade. The gaze tracker provides important information about patient attention. Upward fluctuations are recorded when the patient looks away from the target, and downward fluctuations are times of eyelid closure, which is tracking failure. A high rate of false positives and negatives may occur at the edges of scotomas due to glaucoma, which must be accounted for when evaluating reliability. And clustering of change among adjacent data points is the best way for the practitioner to evaluate areas of possible progression rather than just looking at individual points that don't have clustered depressions around them. So in closing here, we'll say take a deep breath when interpreting a visual field. Take your time when analyzing. This is one of the most important aspects of following glaucoma patients, and there's a wealth of data in a single report that will take a lot of time to digest, and I think taking a deep breath and taking your time is good advice. Compare with previous tests side by side. It's important to put the right eye and left eye next to each other and comparing tests across different visits. And then take time to educate the patient so they understand why they're taking the visual field test. And also some of the important points here from an educational standpoint is to realize that the patient is very nervous when coming in for their visual field. This is a high stressful visit for a lot of our patients, and taking time to educate them and informing them about some of the tricks they can use to get more comfortable while doing the visual field will go a long way. I'd like to close by thanking the organizers for allowing us to give this lecture. On behalf of Dr. Suhu and Dr. Seibold, we hope that this course, this visual field discussion is very useful and that you can come back to this online version over and over again as you go through your training and beyond. Thank you very much.